Good morning, everyone. Good afternoon, good night, depending where you are. So here we are again in this special Global Virtual Morning Report, where we try to highlight voices from all around the world. This is a very special platform for us because apart from the CP servers, we don't get this opportunity of hearing from people from all around the world, very clinical reasoning. So this is very special for us. And thank you for taking your time to spend the Saturday with us. So here, I'll be leading this session with Ravi, who didn't give me any other choice. And also with the help of my CP Silvers team members and friends. So maybe they can introduce themselves. And something that we do often here is to talk a little bit about our own country. So maybe they can share what did they have for breakfast or lunch. So why don't you go ahead first, Andrea?
Hi, everybody. I am Andrea. I'm from Peru. Yesterday was the Peruvian Day of the Medical Student because we have a medical student who died trying to doing research about a disease. So yesterday was the Day of the Medical Student. So happy day to all the medical students that are joining us today. I'm going to pass it to Valeria, that is also Peruvian.
Thank you, Andrea. I am very excited to hear Rafa facilitate today. He's going to do amazing. And please volunteer if you have a case. As Andrea said, yesterday was the national holiday for medical students because of the discovery of urea fever, which I know is a favorite of Kushal and of the VMR crowd. So super excited for today. Please volunteer and feel free to also type in the chat because we're going to highlight all your amazing input. So yeah, maybe I can pass the mic to Kirtan.
Yes, good morning, everyone. I'm so excited for today because of two reasons. First is that Rafa's English is awesome. All of us know that he is lightning fast. And furthermore, the sweet interactions of Rafa with Rabi, we know how they, kind of bully each other. So I'm so excited for that. And briefly about my culture and regarding medicine, I wanted to say that recently, since last 1 or 2 years in our hospital, there have been lots of cases of Wilson's disease, both in pediatric patients as well as the adults. And we have not encountered this before. And as long as we know, it is not one of those diseases which we encounter in India or at least in our part of the India. So I am actually a bit confused at how we may approach it. And I was just yesterday talking to one of our attendings and residents that do you have any ideas like what may be causing this? Is there any risk factor which is, tipping people over this? So I am so excited to learn about it. And maybe if I know something and if you guys know something, then please let me know. And if I come to know about something, then I will share with you for sure. And now maybe I will pass the mic to Rabi before Rafa begins.
Thank you, Kirtan, for that very kind introduction. Yes, Rafa and I have a sibling-to-sibling relationship where he's the older sibling and I'm the younger sibling, and I'm constantly nipping at his ankles to make him move. I'm sitting at a cafe after a wonderful run with my sweet puppy, and I'm just so happy to be here. There's nothing. Many of us have been to most of these Saturday VMRs, and my personal record is I've only missed one since the very beginning, because just being here is such a delight. And then I wanted to call out the crowd who have their videos on. It really makes a big difference. Tiago, Hans, Ravi, Drew, Amanda, Daniela, Franco, Sarah, Samuel, and for a second there, Ariana had her video, but as soon as I called it out, I think it was turned off. But thank you so much for showing us your faces. I think it takes that connection to another level. I really appreciate you, and we're especially grateful for Amanda who's presenting a case today. And for that, I'll pass the mic to Rafa.
Okay, so first I just want to ask you guys to tell you guys about an invitation that we have. So on September 25, we're gonna have 2 doctors that were once international medical graduates and now they are associate program directors, internal medicine residency in the USA. So we're going to have Dr. Ravi, who's always with us. He's our dear friend, and also Dr. Elise, and they're going to be exploring their journey, their obstacles, their struggles until becoming associate program directors, and also what do they look for in an IMG applicant. And I think this can be very educational for a lot of people here, and even for American medical graduates as well. So I hope to see you all guys there on that date. And now I'm gonna pass the mic to Amanda, who is my friend from Brazil, and maybe she can introduce herself and we can start.
Hi everyone, I am Amanda. I'm so happy to be here, to be back. And I have a case. It's a normal case, but interesting, and I hope you will enjoy.
So now let's wait for Andrea to start sharing the screen, and then we can start Amanda with the chief complaint.
Okay. Rafa, are you listening me?
Yes, go ahead. Tell us the chief complaint, please.
Yes, so the chief complaint. A 78 years old female comes to the ED complaint of weakness and weight loss.
Okay, so we have a 75-year-old female with weight loss. And now I'm gonna ask the audience, how do they reason through that? How do you approach weight loss and weakness? Yes, yesterday we had weight loss as well. So how would you approach weight loss and weakness? Well, yesterday the discussion was very interesting with, and Ravi shared with us like a lot of G's that we can remember when thinking about weight loss. So maybe, Kushal, are you in a place that you can share with us such a list?
I am, but I don't remember those 10 causes. But
oh, you don't remember? Can anyone remember that? Oh, so we have Valeria that shared with us this incredible input about weakness and inflammatory markers. Could you please elaborate on that, Val, please?
Well, it was actually a question. I'm not sure because yesterday Ravi mentioned the approach of weight loss, thinking about inflammatory and non-inflammatory causes of weight loss. And so I was wondering if maybe we could consider weakness as an inflammatory marker, which could be present, but I think it's maybe not so specific. And also I'm thinking about maybe neurological causes that, I mean, if it's true weakness or if it's just fatigue, that maybe could be more contributory to an inflammatory picture. So I'm not sure if we have enough to call it an inflammatory weight loss just yet.
Yeah, I love your approach, Val, because we often talk about that on Neuro VMR, like to distinguish what is true weakness from asthenia. We know that a lot of diseases can progress with asthenia and not weakness itself, like a neurological problem. So it's always great to keep that in mind. And now we have, I'm sorry if I'm not saying your name correctly, Jasmine Ren. Could you please share with us your input about weakness and weight loss in the elderly? And please introduce yourself. I don't know if I've ever heard from you.
Oh, hello, Rafa. Hello, everyone else. So I am an IMG from India. I'm currently at Rochester. So thank you for this case. It's a nice case. So when this thing, you came up with weakness and weight loss. So I did this question once in which there was this weakness and weight loss, and there were so many possibilities, but ultimately it was a case of elder abuse. So it's just a new thing that when we think of someone in elderly age group and with weakness and weight loss, it could be due to the malnutrition and not giving the proper nutrition to that age group could be a sign of elder abuse. So I was just reflecting that, what I learned from that question. So that was my first guess. But obviously at this stage, we need to consider malignancy and other underlying disease as well.
Yeah, I love today your approach, and I love today's yesterday's discussion. Sorry, because we were thinking the first thing that you have to ask yourself about weight loss in a patient is: do we give a high five or do we keep concerns from the patient? Because we have to ask ourselves: is it intended or unintended? And this is going to be the key for this case as well. So now I see that Ravi is with is with us. So could you please share, Ravi, with us your schema for weight loss?
Hey Rafa, how are you?
Great.
So the 9Ds, I don't blame Kushal for not remembering. Even I had to open it up. But so this is a very rapid sort of a walkthrough of weight loss. So number one, dementia. Number two, patient could be depressed, and commonly we see elderly patients that may not have an appetite due to depression. Then you can have disease, which could be acute or chronic, and that's where, like Valeria mentioned, the inflammatory versus non-inflammatory component. Dysphagia, dysgeusia, if there's diarrhea, so sort of like an inflammatory bowel syndrome or a acute gut issue, drugs, dentition, and then functional disability or dysfunction. So then the 9Ds or weight loss.
I love your list. It's like so full of possibilities that we should explore in those patients. And also, I really love Thiago's approach because he's an endocrinologist. So it's always good to keep in mind the endocrinological approach to weight loss. So maybe you can share with us, Thiago.
Yeah, so when I see weight loss, I think of appetite, and I love to talk about it here because this concept that I have can be challenged. And please, if you have something else to add, because I'm not sure if it's correct, but when I see a patient, if the appetite is preserved or increased, I think about thyrotoxicosis, diabetes, and disabsorptive diarrhea, because in most cases, patients who are losing weight, they have less appetite because of inflammation or whatever. So it's not common to have preserved or increased appetite. And please, if someone can think about other causes of weight loss with preserved or increased appetite, just let me know.
All amazing teaching points. So can you please carry on, Amanda, with the case? Maybe we can explore that as well.
Yes. So the patient complained of hyperexia, inappetence, and asthenia in the last 2 months. She also had 7 kilograms of unintentional weight loss in less 4 weeks, associated with some episodes of subjective fever. So her recent diagnosis with anemia under investigation, hypertension, diabetes, and she has Alzheimer's disease and a previous episode of ischemic stroke in June in 2021. And she has dyslipidemia. Non-allergies, she used ramipril, metformin, pioglitazone, memantine, aspirin, and atorvastatin. And father died due to heart attack, and her mother died by unknown cause, and denies use of alcohol and is a non-smoker.
Amanda, I'm not sure if Andrea could be able to get all the med list. Could you please repeat that again?
Yes. So she used ramipril, metformin, pioglitazone, memantine, aspirin, and atorvastatin. I will say in the chat.
Okay. Thank you, Amanda. So right now we have a case of a 75-year-old female with weight loss and weakness. And we see that this patient had 70 kilos of unintentional weight loss. So we should be worried about this patient. And also when it comes to weight loss, we have to consider many causes, inflammatory causes, including autoimmune malignancy, but also non-inflammatory causes. For example, loss of appetite and even elderly abuse. We should keep that in mind, especially because these patients, they are a higher risk, especially when they have like disorders like Alzheimer's disease. So now we have, I saw a comment that I really enjoyed. Let me see who wrote that. Oh, Samuel, could you please introduce yourself and talk a little bit about your input?
Oh yes, my name is Samuel. I am a medical student in Mexico, and I was just well, I hear about the EBC that she had, and the thing is that she just had it in June, so maybe she's just weak because of the EBC of this of the stroke, and that's why she's not eating that much, and that's why she's weak and she's weight loss. I don't know. We have to think what came first, the weakness or the weight loss.
Mm-hmm. So if you saw this patient in Mexico, what would you like ask the patient next? What would you ask for that? Or like when it comes to labs, exams, what would you be interested to see?
Well, first I would like to see the nature of her anemia. See if she has anemia. Also, I want to check how is her diabetes, because diabetes also can cause the weight loss and everything else, and try to see it from a more wide aspect. In Mexico, it's so common, diabetes and complications of diabetes, so we have to check this always.
Okay, that's such a nice summary. What about you, Franco? Could you please talk a little bit about your anemia approach to this case?
Well, yeah, first of all, I want to kind of go backwards, because when we have weakness and weight loss, I think it is important to see the tempo of when those they happen. Is he lose weight because he was too weak, or did the weight loss make her weaker? Also, the anemia here, I think I want to point out that she has Alzheimer's, so we don't know if she's not forgetting more symptoms here. So I think a good approach is going to study the anemia to see if there is due to a chronic disease or due to malnutrition. If it is chronic disease, we can also point it out that there would be an inflammatory cause or neoplastic cause, or if there is an iron deficiency that can be due to malnutrition, or even we can think an infectious disease here, maybe some parasites that could be here, pointing out that etiology of the anemia. I think the fact that she has Alzheimer's, she had a previous ischemic stroke, I am not quite sure about her true symptoms relate.
Incredible thoughts, my friend. So I see that my friend from Brazil, Danielle, is here with us. So maybe she can share with us what she's going on her mind. How would she approach such case?
Hi, everyone. So as Rafa mentioned, I'm a medical student from Brazil. Honestly, I'm trying to put together everything that people are saying in the chat and trying to figure out how I would approach this patient. And I think it would be important to have the labs to maybe have a more specific approach. But right away, I think that just from the obvious, this is not a patient that we are going to high five when we see that she had a weight loss. That was the first thing that came to mind with the second quote. It is interesting because I just saw that she had some episodes of subjective fever. So maybe that could indicate that this patient has an underlying infection, or maybe an inflammatory cause of all these symptoms, especially since it's an elderly patient. And as we all know, the immune system is usually, I don't know how to say this in English, but kind of in decline. So to have a fever is already hard enough. And with some episodes, that's way more than usual. So maybe infection or other inflammatory causes of all these symptoms could be in the back of our mind. considering that Amanda is presenting and she is presenting, I'm gonna guess that maybe it has something to do with that, maybe infection. And also, I learned actually from a friend of mine who's also here, Sarah, that weight loss, we always have to check for malignancy. So that is always in the back of my mind whenever I see a patient with weight loss.
Yeah, wonderful thoughts, Dani. Thank you very much. And now I just read the comments. Ramla, could you share your input with us, please?
Oh, hi. Thanks. Can you hear me?
Yeah, we can.
Good. I was just going to attend through the chat. A bit about me. Yes, I came into residency as an IMG, but I completed family medicine. So right now I'm kind of in vacation mode until I start work. So thank you for allowing me this space. But yeah, regarding sort of my thoughts, I mentioned that autoimmune disorders really like to travel together, and especially with this patient and their history of diabetes, and we see that they come in with weakness and fatigue. I'm really concerned about, is some chronic inflammatory process happening, or is there also another like autoimmune disorder present? Definitely, I'll be curious to know what the exam is. Definitely, I want labs. I'm already thinking I want TSH, I want CBC, BMP, just to look at everything to get a good picture to rule out what is happening. Especially if this person was to come into my clinic in front of me, considering her age, I also want to rule out things like malignancies as well, because I really get worried if somebody loses that amount of weight and they're weak. So that's another thing in my head. Yeah, thank you.
Oh, thank you, Ramla. Like, it's always great to have an input from a family medicine doctor. So maybe Rabi can share with us what's going on in her mind, please.
I can't believe this is the first time you're facilitating it. So calm, collected, and getting so many people to share their wisdom. That's really all that's going on in my mind, is trying to find ways to help you do better, and it's very hard. And another small thing about this case that I wanted to share, which is that I am right there with the whole chat. And one thing that stood out to me is something that Daniela said already, and I'll emphasize it. The older you are, the colder you are. Okay, remember that. This is analogous to the high five conversation, because medicine is all about these simple truths. So the older you are, the older you are. What does that mean? That means that for even devastating infections, patients who are older may not mount a fever. You know how young children can have a fever of 39, 41 just from nothing, and even can have a seizure? The opposite is true of younger people. So remember, the older you are, the colder you are, which means that if a patient who is at 75 is mounting a fever, there's something not good going on. All right, back to you, Ron.
Incredible thoughts, my friends, as usual. So please, Amanda, can you carry on with the case?
Yes, so the vital signs, we have a BP 130 or over 80, heart rate is 20, no, heart rate is 82, and respiratory rate is 20. SATs is 96% on room air, and her temps is 38 degrees Celsius. And Jen is well appearing, confused, and pale mucous. Pulmonary and abdomen are both normally. In the cardiovascular, we have a regular heart rate, diastolic murmur in the apical area, 2 out of 6 intensity, and extremities and skin are normal.
Okay, now we know that we're dealing with an inflammatory disorder. Now comes the question, which one of them? I really love your approach, Ariana, about like how things can be different depending on the area that you are. Could you please share with us?
So hello everyone, my name is Ariana Pinheiro. I'm from Brazil. I am a medical student from my first year. And so about this case, I would like to know who is with this patient, because I think here in Brazil, when some patient appear for me with this age, I always like to know, is her by herself or not? Why she's here? Because she knows that she's losing weight and she's confused, or someone like some neighbor or someone from family is with her. So I would like to know, because like I type here, I like to work like in some wilderness area, because if I am in some place where I don't have lab, so I like to first do all my questions and see about my patient and see about the family, because like we have a patient with weakness and weight loss. So this first, let's ask, how is inside the family? How is inside the home? Who is take care about you? Do you have company? Do you have husband? Do you have son? So I like always to see about this. And then, of course, like now we have a patient with fever. Now a lab is very important. But before, I like to see all the clinical and then looking for about lab. So I think now I just would like to know about family.
Okay, thank you for your input. Like sometimes we get for granted what we have, like the available resources that we have in the hospital that we are. So it's always important to keep that in mind when we are in areas that we don't have such options, right? So now I saw that Samuel had like a very good comment about this diastolic murmur that the patient presented on the physical exam. So could you please share with us, Samuel? If you're in a good place.
Okay, no, well, I was just doing, it's something that I have in my mind. Always that I hear the diastolic murmur, I always think that it's something to worry about. You should always worry about it if you have a diastolic murmur, and you should inquire more about that. So as well, I was reading the comments, and that with the Fayette sign, the fever plus the bradycardia, it makes you worry about an endocarditis or something like that, the sepsis.
Yeah, like right now I'm rotating pediatrics, and we often hear like murmurs in the kids, right? And we have to differentiate both benign and not so benign murmurs. And one thing that I remember from studying for pediatrics right now is that when we have holosystolic murmurs and diastolic murmurs, we should be worried about the patient, and maybe that also applies to adults. And right now we have like this fever and a new murmur, so we usually have to prioritize endocarditis as well. Not to mention the phage sign that you just said to us, because we have like this higher temperature, but the heart rate is not increased enough to accompany such symptom. So this is also very interesting as well. So Drew, maybe you can share with us about how do you approach like benign and not so benign murmurs?
Oh boy, as soon as I heard the word peds, I was like, oh, ears up. And well, I'll be heading into a night call on the pediatric ward. So this is gonna be something that I'll have to be thinking about. But for pediatrics and adults, I think of this general rule. Anything that is diastolic, any murmur that is diastolic is pretty much always pathological and needs to be investigated. If it's a new murmur, then then assume that it's pathologic and work it up appropriately. There are some murmurs that that are classically benign, things like flow murmurs or what's known as a Stills murmur, where it's basically a crescendo decrescendo murmur where you hear it in certain positions. But generally, as a rule, if you hear a murmur, note it, call for help. Either your attending who may have had more experience with hearing those murmurs, or if you are really worried, then call a cardiologist or get some other means by which you can view the heart, whether or not it would be looking at an EKG or looking at an echocardiogram. Because you don't want to get burned by thinking that a murmur is benign, when in reality it could be heralding something much more serious.
Thank you, Drew. So for personally, it's hard for me not to think about endocarditis when I see fever and a new murmur. So maybe the master clinician here with us, Ravi, can share with us like differential diagnosis for new onset murmur and fever, like apart from endocarditis. What comes to your mind, friend?
Oh, the term master clinician is such an interesting one. People use it all the time, and it's hard not to be honored by it. But I am nothing but a master. The only thing I know for sure is there's so much left to learn. Here's the problem. And I think it actually goes back to what Franco was saying about anemia. Anemia, in this case, if you're approaching it simply, you'll say it's one of two causes. It's either anemia of chronic disease, or it's anemia of a very specific mechanism, which may provide insight about how to solve this case. So, for a moment, close your eyes and picture anemia. On one side, DDX is anemia of chronic disease, no progress made. You still have to figure out what the chronic disease is. On the other side is anemia of a very specific disease. For example, B12 deficiency, which may take you to the ileum, which may tell you this is iliotuberculosis. The same is true of fever plus murmur, same schema. Close your eyes again. On the left side is murmur non-specific as a result of fever. And that means nothing. It just means you have to solve the cause of the fever, because a fever can cause a high output state causing a murmur. Or it can be that the fever is not causing the murmur, and therefore the murmur is causing the fever, endocarditis. See that? Anemia and fever both can lead to non-specific complications of whatever disease process there is, or they may be specific signature of the disease. So if we find out that anemia is from B12 deficiency, very helpful. We have found the equivalent of a specific cause by saying the murmur is diastolic, right? Because a fever does not cause a diastolic murmur. So now we know that the fever and the murmur are separate. The fever is not causing the murmur. But what we don't know is the time course of the murmur. We know the time course of the fever. So could this patient have endocarditis, or does this patient have a chronic murmur with a superimposed infection at the site of the murmur or somewhere else? So unlike, if we take the analogy of what Franco said with anemia, we found a specific thing about the murmur that makes it impossible for the fever to be causing the murmur. But what we don't know is if the fever and the diastolic murmur are siblings like you and me, my dear friend Rafa, or whether they're completely unrelated and the murmur is an innocent bystander to a separate disease process. Why am I worried about that? This murmur, a diastolic murmur at the apex, sounds a lot like mitral stenosis. And mitral stenosis is not usually acute, you know? So this patient may have long-standing mitral stenosis with superimposed endocarditis, or has long-standing mitral stenosis with a new urinary tract infection. But the fever is not causing the murmur, as usual. All right, back to you, Ravi.
Yeah, I love your approach. Like I always have to remember, and I think some people as well, like fever and anemia themselves can lead to murmurs, because fever can lead to hyperdynamic, how can I say that? Like a higher cardiac output, and also anemia can lead to a hyperdynamic circulation. So we have to go search for the cause, right? And also when you said about mitral stenosis, something that I always remember, because I am from Brazil, something that we learn here is to consider rheumatic fever, right? Maybe this could be a sequelae of such disease. So we should be worried about that, like see if the patient had any arthritis on his or her history, and also any history about sore throat or any other symptom that can accompany rheumatic fever. So thank you for your input, friend. So maybe Amanda can carry on with the case, please.
Yes, in the labs we have HB 6.6, red cells 3.0, and I'm attracted in 21%. WBC, we have 18,000, 8% of basophils and 70% of neutrophils. Platelets, 200,000, and kidney and liver function are both normal, and C-reactive protein, it's 70.
So before we start discussing this aliquot again, could you please, Daniela, share your clinical problem representation in Portuguese?
Oh, yeah. Let me scroll up in chat. So I basically just translated what we had already in English. I'm speaking in Portuguese now. Wow. Então, nós temos uma mulher de 75 anos que está com uma perda de peso involuntária de 7 quilos e astenia quando ela vai ao pronto-socorro. No momento da consulta, ela está confusa e apresenta um sopro diastólico. Yeah, that's it.
Thank you. So maybe Arisha can share her differential diagnosis for diastolic murmurs, please.
Here, like anemia, we can see, but in anemia, we have systolic murmurs, whereas diastolic murmurs mostly happen during certain other conditions, like when, like in mitral stenosis or tricuspid stenosis or aortic and pulmonary regurgitation. What happens that diastolic filling gets an additional beat due to which we hear the murmurs. So that's what I thought. And the reason behind all of this can be the calcification and fibrosis, which can happen post-infective endocarditis.
So thank you. It's such a great list.
But anemia does not appear probable here because anemia leads to systolic murmurs.
Yeah, I agree with you. Just like you when Rabbi taught us before, we should not consider that the anemia is leading to such murmur. We should go after another cause. And Jasmine actually had a question about Portuguese here in South America. Just for you to know, I don't know if anyone knows, but Brazil is the only country in South America that speaks Portuguese. All the other countries speak Spanish. I think this is because we were colonized by Portugal, and all the other countries were actually colonized by Spain. So maybe now we can see now, going back to the case, that this patient actually has a very elevated white blood count, the neutrophils being 70%, it's non-funky inflammation, like Robbie teaches. And also maybe someone has I don't know, an input to reflect on such this piece of data. Let's see if I missed someone. How would you guys think about this case right now that we have elevated white blood counts with elevated neutrophils, hemoglobin, a low hemoglobin? Yeah, me too, Drew. Could you please elaborate on that?
Typically, basophils do not go anywhere of 1% of your blood count. Anything that any time that you see either basophils or eosinophils go anything above like 1% or anything, or anything like that, I start to get very worried. I don't know if this is just a reaction to an infection and the basophils are just going up in proportion, but that's still quite high. And it makes me wonder whether something else is going on besides the top diagnosis that I think we have, at least the consensus that we have is that we're looking for an endocarditis somewhere.
What about you, Hans? We didn't hear your voice today. Could you please share your input in the case so far?
Yes. When I was looking at the labs, at this point, I'm too stupid to interpret them because I can't make up why the basophils are so high. Just as Drew said, we are thinking about something going on, but at that point, we don't know. The only thing that I could explain is possibly the diastolic murmur. It could be related to the anemia, and the anemia could be related to something underlying. That could be an inflammatory state over a longer period of time, because it could be an anemia of chronic disease, but it could also be anemia of chronic disease secondary to an infection, of which I'm not aware of either. And of course, I don't want to rule out a malignancy either at this stage, because it is possibly inflammatory. It could be a liquid tumor. She's 70 something old. So I was thinking about leukemia, chronic leukocyte leukemia, something like this. But it's all open at this point. And
I totally agree with you. And thank you. You're always like very welcoming and always give us such nice input. So thank you very much for sharing that with us. And I absolutely think like when I see such high basophils, I tend to worry about like myeloproliferative disorders, such a hard word to pronounce in English. So this is something that we should keep that in mind. Vale, could you share your input with us as well, please? What do you think is going on so far?
Oh, sorry. Yeah, actually, I was just surprised because of the fact that Ravi mentioned in the chat, and I was Googling as well, the fact that we could have causes beyond malignancy of basophilia or increased basophils, such as hyperthyroidism. And well, malignancy, of course, is high in our priorities to rule out, but also something like an allergic reaction could lead to basophilia. And so I didn't know that hyperthyroidism could cause this change in the WBC. So something new to learn.
Yeah, me neither. So we are here to learn, right? So Amanda, can you please carry on with the case?
Yes. So we have urine analysis without change, AKG without change, and X-ray present with a significantly cardiomegaly. And I have 2 exams that give us the diagnosis. I stop or I say?
Oops, I was muted. Could you share with us all the aliquots before the last one, before revealing the final diagnosis?
Yes, so it's just that exams I just said, and AKG without change, urinalysis without change, and X-ray present with a significantly cardiomegaly.
Okay, so you have just one more aliquot that will reveal the diagnosis, right?
No, I have, yes, 2 exams give us the diagnosis.
Okay, both of those two give us the final diagnosis.
Yes.
Oh, wow. Okay. So now maybe Ariana can share with us what she's thinking.
Okay, Rafa. Hold on. I need to think a little bit more. But
No pressure.
no pressure. Thank you. But I'm really thinking about Chagas too. But okay, hold on. Give me more minutes and I can answer you. Okay.
Okay, no problem, no problem.
Okay.
So could you please, Ravi, share with us your input?
Oh, were you asking me? I didn't know if you said
Yeah,
Ravi.
yeah.
Oh, okay.
Yeah, it's hard to distinguish both sometimes.
Yeah, a couple of times you mentioned Ravi, I'm like, oh, maybe I should jump in. I was sort of thinking, you know what, this endocarditis is being thrown around quite a bit, and then the basophilia, and like Valeria mentioned, malignancy, and a lot of nice thoughts, great info from the chat, Kushal as well, and you know, when I try to put them all together, and I remembered like, okay, SLE has Liebman-Sachs endocarditis. Well, malignancy has this endocarditis called merantic endocarditis. So that was just something I put together as a teaching point.
Yeah. What about Ariana? Ariana, place just to talk? If not, that's totally okay.
Okay. So I don't know how to say pathognomonic in English. So
Pathognomonic. It's basically the same.
And when I see this cardiomegaly, the first thing that I just bring on my mind is Chagas. So we have high basophilus and fever, and this oh my god, I don't know. So anyway, I see this cardiomegaly, my first thought is Chagas. So now to agree with this thought is this CRP is high, fever, maybe this about mucosa. I don't know if confused is a symptom from Chagas. I really don't remember right now. And the main symptom is weakness and weight loss. So now maybe I am following two Chagas. I don't know if someone can agree with me and can help me, but yeah, this cardiomegaly just bring me to Chagas.
Okay, yeah, it's super important to consider the local epidemiology that this patient is on, right? Like she's from Brazil, and we should keep that in mind. So maybe before Amanda can, sorry.
So okay, can I do a question?
Yeah, please go ahead.
Okay, like you said, where this woman come from? So I would like to know what city or what area she is from. Do you know if she said to the PS? And of course, like here in Brazil, we always ask how is the kind of house? Because if it's a wider area, if she has like a house where we can have Chagas, you know what I mean? So I would like to know more about this.
Okay. The epidemiological factors that the patient may be exposed to.
Exactly.
So maybe before Amanda can reveal the diagnosis, maybe Val can share with us her problem representation in Spanish.
Okay, so this is the case of a mujer de 75 años que tiene pérdida de peso involuntaria de 7 kilos y debilidad se presenta en emergencia. Está confundida y además tiene un murmullo diastólico en el examen físico. En los exámenes es solo relevante que tiene leucocitosis con predominancia de basofilios y anemia. Y bueno, la cardiomegalia. That would be
yes. Thank you, Val. So maybe Ravi can share with us what he's thinking right now.
I texted Rafa to have the chance to say something because I want to share a piece of advice. In real life, we are at risk of making an error. And let me tell you why. This person for sure has a cardiac problem. The evidence for that is very strong. there's a murmur, and there is cardiomegaly. Heart problem. Fever plus heart problem, endocarditis, rheumatic fever, Chagas.
Thank you for your input. So maybe now, I don't know, maybe you, Sarah, can share with us like something that you learned today in Portuguese that you enjoyed, if you're in a place to speak.
Yeah, of course, I'd love to. Do I have to say this in Portuguese, or maybe I should speak
Oh,
English?
could you, no, could you please share that in Portuguese, please?
Oh, of course. Sobre o caso todo ou só sobre...
Alguma coisa que você aprendeu hoje, que você gostou?
Nossa, para mim foi muito legal. Assim, como a gente mora no Brasil, a primeira coisa que a gente sempre pensa, por exemplo, as chagas agora que veio, ou causas malignas, algo assim. E ver que essa questão da basofilia, tantas coisas que não são comuns aqui, que a gente pôde ver que teve uma outra visão nos Estados Unidos, por exemplo. Então, eu achei isso muito legal.
Yeah, so what Sarah was talking about is how different is the clinical reasoning when you're in certain place in the world. Like, this is something that we really like in GVMR, because we can reason through from the eyes of international audience, and this is just magical for us. So maybe Andrea, can you please share with us like a teaching point in Spanish?
Ya, tenemos, por ejemplo, a mí me gustó bastante las 10 Ds para la pérdida de peso, que es demencia, depresión, enfermedad que puede ser aguda o crónica, disfagia, diarrea, disgeusia, drogas, problemas con la dentición, con los dientes, o incapacidad funcional.
Thank you, Andrea. Do you want to give us a final input, Robbie, before revealing the final diagnosis?
Oh, sorry, I froze earlier.
No problem.
I just wanted to say there's a big risk that we're making an error in real life, because the patient has very good evidence for heart disease, cardiomegaly, and diastolic murmur, but that is very hard to marry with basophilia, very hard. So in real life, I would be chasing two separate diagnoses. What's in the heart and what's the cause of basophilia? Because they don't marry very well very quickly. Of course, we may learn that Chagas has basophilia, maybe, but in this case, I would consider sending a BCR-ABL for chronic myeloid leukemia, or CML, because the most common cause of basophilia is CML. The most common cause of fever and diastolic murmur and cardiomegaly is ischemia, Chagas, rheumatic fever, yes. The most common cause of basophilia is CML. So do both and see what happens. Don't assume that it all comes down to one diagnosis, especially when you're having a hard time putting it together. That's my advice.
Yeah, I totally agree with you. And we have to remember something that we always say here, that patients don't read textbooks, right? They can have as many diseases as they want. So could you please share with us, Monda, what happens to the patient?
Yes, so we have echocardiography with aortic valve vegetation and blood culture positive for enterococcus SCP, with final diagnosis infective endocarditis.
Infective endocarditis by enterococcus. Did I hear correctly?
Yes, enterococcus.
Okay, thank you for the case. Very, very interesting. Something that we should always keep in mind. I really enjoyed like facilitating this discussion. I didn't have any work at all because I have such an incredible group with me. So thank you everyone who shared your input. You guys made my job so much easier. So thank you very much. So maybe now Vale can share with us her teaching points.
Yeah, I am left with a question if maybe the basophilia could be something else or could be explained by this enterococcus infection. But thank you for that case, Amanda. It was really great. And so when approaching weight loss, Ravi taught us that we should first differentiate causes that we will congratulate the patient for, as if it was an intentional weight loss, or do we worry for this unintentional weight loss? And the approach is in two categories: inflammatory causes versus non-inflammatory causes, in which clues of inflammation include fever, leukocytosis, thrombocytosis, anemia, elevated inflammatory markers, and hypovolemia. And Ravi taught us his 10 Ds of weight loss, which include dementia, depression, diseases, acute versus chronic, dysphagia, diarrhea, dysgeusia, drugs, problems with nutrition, and functional disabilities. And I really love this prologue by Tiago, where he mentioned 3 causes in endocrinology that could lead to weight loss, but preserve or increased appetite. And it should be red flags to think about thyrotoxicosis, diabetes, and malabsorptive diarrhea. And then Franco mentioned kind of an egg before chicken or chicken before egg problem, which we're thinking what came first, the weight loss or the weakness. And with the anemia in the equation, and the murmur, we're also thinking if the anemia could be the cause of the murmur, if something like a chronic disease, like a malignancy, could lead to the anemia, and this could explain the weakness, or maybe the patient that had a past medical history of a stroke could have weakness, and because of this, and because of his dementia, could have malnutrition. This could lead to anemia, and the anemia could explain maybe the weakness and the new murmur. But then Ravi also mentioned us that the patient had fever, and so we had to be careful, because the older you get, or the older you are, the colder you get. And so another patient with fever is a red flag for inflammation. And the patient had a phaget sign, which is a really famous sign because of the infections that we have here in Peru. Basically is fever plus bradycardia, and could explain, usually I think about dengue, chikungunya, and yellow fever as the 3 main causes, but also Kushal shared other infectious etiologies such as Legionella, Salmonella typhi. And then we were thinking, in pediatric patients, we have a lot of innocent murmurs, and so we should differentiate what is pathological versus what it could be benign. And so the 7S to characterize an innocent murmur are soft, systolic, diastolic murmur is always pathological, then short duration, normal is 1 and is 2, symptomless, and the changes with position, and also that other auxiliary tests are normal. And then we came with an impressive finding, which was the basophilia, which still is a question without answer. I think that what could explain is high basophils, and we should think prioritized malignancy, CML as the first cause and the primary cause, and then other causes such as hyperthyroidism, acute infection, and an allergic reaction. And then Kushal also mentioned the possibility of a false elevation of basophils because of a longer time processing the sample. And then also the possibilities such as Marantic endocarditis, part of a malignancy picture. And Ravi, to end, taught us about the thing that we were thinking about, cardiac or something affecting the heart, plus fever. We should think about endocarditis that ended up in the final diagnosis, but also Chagas disease because of the epidemiology, and rheumatic fever as well. So thank you so much for attending, and Rafa, you did an amazing job today facilitating.
Well, thank you, everyone. This was such a blast. Maybe Ravi can share his final input about this session.
We love you, Rafa. Bye.
See you guys. Have a good weekend.